I'm Dr. Margaret Lafferty, live from the 2017 Hot Topics in Neonatology meeting in Washington, D.C. I'm joined by Dr. David Tingay from Melbourne, Australia, and we're here to talk about his discussion about positive end expiratory pressure in the neonate. Welcome, Dr. Tingay.
Thank you very much.
Absolutely, thank you for being here. Dr. Tingay, can you tell us about the major objective of your talk?
So my major objective is really to talk about how we're considering the application of PEEP in NICU practice at the moment, both generically across our management of all babies, but also specifically within the care of the baby at birth and the care and the management application of respiratory support in the delivery room.
All right, and can you tell us more about the research or work you've done related to this?
So we've been looking at how best to apply PEEP now for more than 10 years in our group. First in newborn infants in the NICU receiving with severe respiratory failure, needing respiratory support with high frequency, and then more recently using non-invasive ventilation. And in our animal program, we've been particularly interested in trying to understand how PEEP may be applied in the delivery room as babies go from their fetal state, which is one of a lung full of lung liquid, to needing to rapidly aerate and start tidal ventilation. And we feel that this is a situation, or a clinical situation at least, where the application of PEEP may be most beneficial and easiest to optimise rapidly.
Can you tell us about the details of these animal studies?
Yeah, so what has become clear to us over the last 10 or so years is that most clinicians are actually quite comfortable using PEEP. This is not a new therapy, in fact it's older than I am. Most people say, well, why are you even bothering to do this? I use it, I do it every day. But I think we've become complacently comfortable. And when you ask people why they pick the PEEP settings they set, they actually can't give you a good answer. And I think this has almost become sort of old knowledge that we don't really know where it's come from. And when you go and ask people even further, well, how do you pick those numbers? They'll say, well, I know that I can't be PEEP-ophobic, and I'm definitely not PEEP-ophobic, but I don't like to use high PEEP either. So how do we work this out is the question we were interested in evaluating. And we know that too little PEEP is bad. We know that too much PEEP is bad. We know that there's somewhere in between, there's this just right Goldilocks kind of component to it. But at the bedside, we don't know how to do that. We don't know how to find it. And I think most clinicians have just gone, well, it's all too hard, so I'm just going to pick 4 or 5 or 6 or 7, and I'm just going to use that, and I kind of think that'll be okay. And we never really question it. Even when we look at RCTs of different therapies, we all just assume someone's used PEEP and it must have been right. So we've sort of said, well, okay, we don't know exactly what PEEP to use in a baby, and we know that at one stage of disease you might need a different PEEP than another stage. But we know that when you change PEEP, you change lung volume. And we know from our high frequency work that doing that we change oxygenation. So maybe we should look at applying PEEP dynamically. And by dynamic, I mean firstly saying, well, not every baby should have the same PEEP. So just changing my thinking at the bedside. But also within a baby, knowing that the PEEP I use today may be different from the PEEP I need to use tomorrow. And then saying, well, okay, I can even be more specific and say, well, if I make rapid, small changes in PEEP and do it consistently, as long as I can understand what's happening to the baby in terms of the lung volume and getting some feedback, then maybe I can get the right PEEP for that baby. And our lamb work in preterm lambs at birth showed that the lamb lung, as we know, is very atelectatic because it's got bad HMD like our preterm babies, and we know that the HMD lung needs to be recruited, and it needs quite a high pressure to get recruited. So we did a series of stepwise increases in PEEP, and then but the lung doesn't need to be held at that high pressure. Harm can come from that. Once the lung is recruited, it actually will keep that recruitment at quite a low PEEP. So then we quickly decrease the PEEP down. And that manoeuvre is completed within the first 180 seconds of life in our lamb group. And in fact, in our early studies, we let them go up to a PEEP of 20 and found there was actually less pneumothoraces than if we just put them on a PEEP of 8 and positively pressure ventilated them. And we've subsequently gone and refined that strategy a bit more, and we've also compared it to sustained lung inflations and showed now in about 6 or 7 studies and many, many hundreds of lambs that it's this dynamic use of PEEP in birth to try to clear lung liquid, recruit the lung that then back off, that actually improves short-term outcomes in the lambs, and we're now starting to see we can get an injury difference. So we think that we're now at the point where we've done enough work on lambs, and maybe we have a way of testing this in the bedside as a clinical trial sort of therapy.
That sounds great. What would you say is the most surprising thing that you found in looking at these lambs and the PEEP?
Well, the thing that really struck us was what happened when we then gave them surfactant after.
Okay.
And we were giving the lambs surfactant at 8 to 10 minutes of life. And we found that lung compliance dramatically increased after we gave surfactant in the lambs that got a dynamic PEEP. But the lambs that were given a sustained inflation at birth and then just ventilated with a PEEP of 8, there was no compliance increase after surfactant, which suggests that maybe being aggressive with our PEEP and thinking about PEEP as a dynamic entity at birth may actually have a synergistic effect with surfactant.
That's interesting. Can you go into a little more detail about these lambs and the work that you did with them? And
so Australia has no shortage of sheep. So it's quite easy to get hold of sheep. And the preterm lamb is quite a good biological model for preterm lung disease. Mm-hmm. It's not necessarily an equivalent mechanical model for lung disease, but the exact numbers are not translatable, but the concepts are. So we use lambs that are equivalent to depending on our study, between 23 weeks and 28 weeks gestation. We've investigated these recruitment manoeuvres or aeration manoeuvres at birth in lambs that have been exposed to steroid, lambs that have not been exposed to steroid, lambs that are then given surfactant and lambs that are not given surfactant. So we've looked at different entities and different permutations. One thing that we have tried to do in our studies is to avoid lambs that have got fetal distress or have had evidence of choriamnitis. So these are sort of our nice, good babies generally, especially in our last studies. We've particularly focused on very fetally stable lambs that have grown well in the womb, have been exposed to steroids, who've got nice, good, controlled mothers, and worked on them as our population.
All right. What would you say is the main takeaway point of your talk?
For me, the message I would like to get across is not about lambs. But if people could come away and say, when they go back to their NICU and say, well, am I really someone who is thinking of PEEP as something that I can change in my practice, and to not think about PEEP as a number, but to think about what the problem the baby has. So if the baby has an atelectatic disease, should I be thinking about using a higher PEEP than I might be already doing? But similarly, if the baby has gas trapping or hyperplasia, that baby's not going to benefit from a high PEEP. Is that the baby I need to use a lower PEEP than I might be doing in my practice? So encouraging clinicians to be thinking when they're looking at their patients. That's the message I'd like to get.
That's great, thank you. And you mentioned a little bit about this, about a future randomized control trial using babies. What would you say is the next step? Where do we go
we're
from
actually
here?
in the process of trying to get this trial funded, and we have some funding to do a pilot trial this year in Melbourne, and we're searching out advice from international experts on how to refine aspects of the protocol. But the trial we're intending will be a trial of standard NRP of a PEEP of 5 to 6 as a control group, and the classic Mr. Soper escalation component versus allowing babies to be started at a PEEP of 8 with all other aspects of NRP the same, and then at 2-minute intervals having assessment of the baby's condition, and if the baby is not improving, to increase PEEP to 10, a maximum of 10. If the baby is improving, there's no evidence, there's no reason we should go up high. And then in babies where the PEEP is increased, to then have built in an algorithm that would allow the clinician to decrease PEEP after the baby improves. So it's both a dynamic and high component versus a static sort of concurrent one. And we're looking at babies who are being between 23 and 28 weeks completed weeks.
Well, that's great. Thank you very much, Dr. Tingay.
Thank you very much.
That's it for us here at the Hot Topics for Neonatology Conference in Washington, D.C.